so glad to be joining you all today. I'm Menopause Barbie, your menopause tailor, teaching you all you need to know about menopause and the rest of your life. We're in the middle of some tutorials about the healthcare system, insurance, and doctors. And I'm giving you practical information that will help you all manage your menopause your way. But there are some hurdles in managing your menopause your way. And one of the biggest hurdles is that very little in the world of medicine is about doing things your way. And more significant than that is the fact that very little in medicine is about you, period. And that's because much of medicine is focused on populations instead of on you personally. So this tutorial is all about population versus personal medicine. Now, if you're wondering why you need a tutorial on population versus personal medicine, then you really need a tutorial on population versus personal medicine. Because as much as you may think you're getting personalized care when you go to your doctor to discuss your personal situation, wants, and desires, you aren't. The problem is you don't realize that so much of what goes on between you and your doctor has absolutely nothing to do with you. It has to do with the whole population. So I'm going to teach you how this focus on the population rather than on you personally affects you. And I'll give you some tools for getting the focus back on you. Much of what I'll teach you comes from my master's in business administration. Mine focused specifically on the healthcare industry. So you're kind of getting a little mini MBA in healthcare. We'll start by discussing the historical basis of medical care. It'll help you understand how things have gotten so impersonal. So, way back in the olden days, before there was medical insurance, medicine was a very simple industry. There weren't many doctors, and there weren't many real cures. Doctors practiced medicine independently as solo practitioners, and patients went to the local doctor, they received the advice and treatments offered by that local doctor, and they paid the doctor in whatever way they could. Sometimes they gave the doctor live chickens or baked goods. Sometimes they swapped services. So if the patient was a tailor, he might make the doctor suits in exchange for his medical care. And sometimes the doctor received cash payment. But the medical industry was all about helping people, and doctors did whatever they could to help people. Each patient was unique. So the relationship was entirely personal. There was no middleman. Then, medical insurance came along. At first, medical insurance didn't interfere with the doctor-patient relationship. You and your doctor decided what was best for you, and the insurance company paid whatever the doctor charged. With time, insurance started paying only what it considered usual and customary charges for medical services. They would assess payment by populations. The usual and customary charge was the average charge for a particular treatment by physicians in the same local region. So this was application of population medicine for purposes of payment only. But notice that the population of focus at the time was the population of doctors, not patients. Next, the insurance industry began dictating what it would pay for. So instead of limiting how much it would pay, it also limited the services for which it would pay. Now, this may not sound like population medicine to you, but it most definitely is. And that's because the insurance company would pay for the treatments and procedures that were most cost effective for the insurance company. Whenever the focus shifts to what's most cost effective from a business standpoint, you no longer get personalized medicine. Your personal preferences become secondary to what's cheapest for the insurance company. So this set the stage for the next level of population medicine, which is called cost containment. Cost containment involved finding ways to limit spending on patient care. Well, you know what? There's only one way to limit the cost of patient care, and that is to limit patient care. More precisely, it's a limitation on personalized patient care. Now, this cost containment has taken many different forms over the years. In the 1990s, it was in the form of HMOs, or Health Maintenance Organizations. And HMOs involved a fixed payment per patient per month. Thereafter, the thrust to contain costs took many other forms, including PPOs, which are preferred provider organizations. And that was a contract with medical providers in a particular network. Another form was patient-centered medical homes, in which treatment was coordinated through primary care physicians to avoid redundancy and trim costs. And another form was bundling of procedures together so that one price covered the entire bundle of services entailed in a single disease diagnosis. As all these new models tried to contain costs, they started shifting into terminology that focused on quality of care rather than containment of costs. And other models started appearing that had names implying better value. One of those was value-based care. This one promised improved quality and better outcomes for patients. And another was pay for performance. It was directed at physicians. They only got paid if a certain percentage of their patient population achieved certain standards. In essence, it shifted accountability for your health outcomes to your physician. So if your blood pressure wasn't controlled, it was the physician's fault. If you didn't follow your diabetes diet, it was the physician's fault. Even though your behavior has a lot to do with your health, it placed all the responsibility on your physician. And if you didn't do your part, your physician wasn't paid. See, most patients have no idea that any of these models ever existed and that some of them still exist today. Now, the problem with all these models is that they are not focused on your personal quality of care or outcomes. They focus on either the entire community population of patients or on an individual doctor's population of patients. So instead of making sure that you get your mammograms and bone density scans, they focus on making sure a certain percentage of the entire population gets them. They're all about statistics. And statistics always look at the whole population. They are not about you. In the process, you become more lackadaisical about being on top of your own care. These models make patients think that quality care measures will keep them healthy. They won't. Okay, next came electronic health records. Everybody is so fascinated with technology these days. So when the medical industry first started using computers, they were targeted only at billing. But then their use spread to include coding for diagnoses. And next, they were used to chart patient data. You probably remember the first time you went to your doctor's office and a computer was in the room. To those of you who are old enough to recall the days when the doctor looked at you and examined you and interacted with you personally, suddenly it felt like the doctor was taking more care of the computer instead of taking care of you. Everything is in the computer now. Your medical history, your exams, your labs, your diagnoses and their codes, your medications, your billing data, and your insurance. And once that all that information got put into the computer system, it was possible to track everything. Now, this was supposed to improve the quality of your care. But what it improved was the ability to control costs. And you know what? The different electronic health record systems cannot communicate with each other. It's like Mac and Windows. Their programs are not interchangeable. So all of this computerized data is great for tracking what's going on a population-wide level, but it's a disaster on the personal patient level. Instead of making it easier for your doctor to do what's best for you, it makes it nearly impossible. For instance, if you want a particular HRT for your menopause, a particular type of HRT, the computer may not let your doctor order it if it isn't allowed by your insurance. You may want it, your doctor may want you to have it, but the computer disallows it. So the next development was conglomerates. And conglomerates involve mergers of big hospitals and medical industries into even bigger organizations. And what does that do? It creates dominance of the market. So instead of having a lot of choice as to where you want to get your medical care or which doctor you go to based on practice style, you discover that they're all part of the same system. Doctors never wanted it this way, but the constant market pressures made it impossible for them to be able to have independent practices. It was merge or perish. And once they had merged or sold their practice to a hospital, they had to follow the rules of the purchasing entity, in addition to following the rules of your insurance company. And that's not all. There's another layer of population medicine that limits your options. Do you remember the tutorial I gave you on guidelines? That was video number 91. Guidelines are what the medical industry uses to determine when you need a screening test, like a mammogram or a bone density scan. And guidelines are created by a committee of physicians and insurance companies and patients and equipment manufacturers and health associations and public health authorities. So they all get together and sit around a table and they decide when and how often you should get a test. But it's not based on what's best for you. It's based on what's best for the population. Guidelines are population medicine. They are not personal medicine. So the guideline may say that you should get your first bone density test at age 65. But you may be at high risk for osteoporosis and need your first one at age 50. And when you combine the guideline, plus what your insurance will pay for, plus what the pay for performance standards require, plus what the electronic health record will allow, there is nothing personalized about your medical care. Do you see how far off the mark this can be from what you need as an individual? I get comments every single day from women who have an obvious need for a bone density test, but their doctor doesn't order one. The reason I teach you this stuff is so that you realize the system is all about the population and not about you. You have to take care of you. And I'm giving you the tools with which to do just that. Sometimes that will mean that you need to pay for something yourself. Sometimes it will mean that you need to find a new doctor. Sometimes it will mean that you need to ask your doctor to call your insurance company. It may take many different forms, but the very first step is for you to know that the focus of the medical system is on the population, not on you. Another area where this focus on population overshadows you is in research. Whenever you hear about a research study, the most important thing you can do is find out how similar the research subjects are to you. The researchers did not study you personally. They studied a population of people. Your job is to tailor the findings of the study to you. And you can't do that if you know nothing about the research subjects. So never react to a research study without knowing more about the specifics. Here's an example. I have severe arthritis, and I take an anti-inflammatory drug called Celebrex. Celebrex has been shown to cause heart attacks in a lot of the arthritics who use it. So should I stop taking my Celebrex? Should I worry that it's going to cause me to have a heart attack? Well, here's how I decide. I consider the characteristics of the average patient with arthritis and the people they studied. They aren't health nuts. They don't go to the gym every day. They aren't vegans. They don't have perfect cholesterol values. A lot of them are a lot older than I am. They're overweight. They have other health problems. They're at high risk for heart attacks even without the Celebrex. They have nothing in common with me except the fact that they have arthritis and they take Celebrex. So, should I reduce the quality of my life by discontinuing my Celebrex, or should I continue taking it because my risk for a heart attack is so low? The study on Celebrex didn't study me. It studied a bunch of people who are very unlike me. So for every research study, you have to tailor the results to you and then decide what's best for you. So, speaking of population versus personal medicine, I'm going to take this opportunity to give away another one-on-one consultation. They're all about you. You can enter this drawing no matter where you live because I do them in person, on Skype, on FaceTime, and on Facebook Messenger. So wherever you are, I can do a consultation with you. So this drawing for a one-on-one consultation will be open for 1 week. It will end at 11:59 p.m. Central Time on December 17th, 2018. If you win, you'll be able to indicate all the things you want to discuss and send me any labs or tests you want to address. You'll be able to tell me all your details, and I'll prepare a document with all the background education as it applies to you. I'll incorporate all your issues, all your labs, all your stuff into it. I will personalize it as far as your doctors, your insurance. I will do the whole thing for you. It will be the ultimate in personalized medicine. And I'll send you that document at least 24 hours before your session. It's usually about 6 to 12 pages long, sometimes much longer. But that gives you time to read it beforehand, know all the background, and then during the consultation, I have all sorts of props and models to show you, and we make great headway in tailoring all the options to you and make sure that everything is tailored for you. Okay, I'll include all aspects of the healthcare system into you. This is what I do with all consultations. It is the most personalized thing you've ever imagined. So you can sign up here, or you can go to my website, which is menopausetailor.me. So the summary of this tutorial and what this is all about is that you have to realize that nearly everything about your personal medical care is diluted by population medicine. And it's up to you to shift the focus to you. And if you need me to help you do that, I can help you do that. You have to learn everything I teach you and know the facts, and then you get to use that information to decide what's best for you. Don't let the latest population medicine model dictate your care. No one will ever take care of you as well as you take care of yourself. And you can't take care of yourself without education. Okay, so that's the end of my message for today, and I hope you realize that you can count on me to tell you the truth. I am not trying to sell you any menopause remedy. My product is education, and I'm a credible resource, and I hope you can see my dedication to you and your health. My goal is to provide you with every resource you need regardless of your timeline, your learning style, or your budget. Every woman on earth deserves this education. And I dream of a day when every woman learns all of this in her 30s. Can you imagine how powerful it would be for all women to know this at a young age? That's what I call Menopower. So let's make that happen. Okay, follow me in the next week on Facebook, Twitter, and Instagram. Subscribe to my channel, and I will see you in a week. Bye.